All right, let's talk about irritable bowel syndrome. This is absolute bread and butter stuff for us in primary care, but getting the diagnosis and management right can totally change a patient's quality of life. We're going to walk through the latest NICE guidance to make sure we're all on the same page. Let's get into it.
So here's how we're going to break it down. We'll start with that initial gut feeling, pun intended, when you first suspect IBS. Then we'll cover how to make a positive diagnosis while keeping an eye out for red flags. After that, it's all about management, starting with diet and lifestyle, then moving through the medication steps, and finally, what to do with those tricky refractory cases.
And just to get a sense of scale here, we're talking about 10 to 20% of the population. That's huge. It means we are seeing patients with IBS every single day. And while it might not affect how long they live, the impact on their day-to-day life, the morbidity, can be absolutely massive.
Okay, before we even think about diagnosing, we've got to get our heads around this core concept, the gut-brain axis. IBS isn't just a tummy bug, it's now understood as a disorder of communication between the brain and the gut. This miscommunication leads to two key problems: visceral hypersensitivity, where the gut is just way more sensitive to pain, and that disordered motility that gives you either constipation or diarrhea.
So when should the alarm bells for IBS start ringing in a consultation? Well, NICE gives us some really clear criteria to kick off our thinking process.
The approach here is simple and structured. First, you suspect it based on the story they're telling you. Second, and this is the crucial safety netting step, you actively exclude other, more serious conditions. And only then, once you've done that, can you confidently make a positive diagnosis of IBS.
Now, the first big filter, the really critical point for even starting to think about IBS, is time. According to the guidelines, the patient needs to have been dealing with this mix of abdominal pain, bloating, and changing bowel habits for at least 6 months.
All right, so you suspect it. Now let's dig into how we actually confirm that diagnosis, while always making sure we're screening for those critical red flags to keep our patients safe.
And this, right here, is the absolute cornerstone of making the diagnosis, taken straight from the NICE guidance. The pain isn't just random abdominal pain. It has to be connected, somehow, to going to the toilet. Either it gets better after they go, or it's linked to a change in how often they're going or what their stool looks like. That's a key differentiator.
So, to really lock in the diagnosis, we have this handy 2 of 4 rule. Along with that pain we just talked about, you need at least 2 of these features. Things like straining or urgency, bloating, symptoms getting worse after eating, or passing mucus. It's a really practical checklist. Now, this slide is probably one of the most important ones, both for your day-to-day practice and for your AKT exam. These are the red flags you absolutely cannot afford to miss. Things like unintentional weight loss, any rectal bleeding, or a new onset of these symptoms in someone over 50, that should make you stop and think about other possibilities, like bowel or ovarian cancer.
This is all about investigating smartly. What do we have to do and what's just over-investigation? Well, we must screen for anemia with an FBC, check for inflammation with a CRP or ESR, and rule out celiac disease. And it's a good idea to consider a fecal calprotectin to help tell it apart from IBD. But, and this is key, if a patient fits the IBS criteria and has no red flags, routine scopes and scans are generally not needed.
Okay, so you've made the diagnosis, you've ruled out the scary stuff. What now? Well, the first step isn't reaching for the prescription pad. It starts with simple, effective lifestyle and dietary advice. This is the foundation of good IBS care. This is the foundational self-help stuff that really empowers the patient. It's all about regulating habits. Eating at regular times, staying hydrated, cutting back on known gut irritants like caffeine and fizzy drinks. And don't forget to encourage exercise and relaxation. That directly targets that gut-brain axis we talked about. Okay, AKT hot tip right here. This comes up all the time. We often tell patients to eat more fiber, but for IBS, the type of fiber is absolutely critical. We want them to have more soluble fiber, things like oats and aspergilla husk. But you need to advise them to reduce or even avoid insoluble fiber like bran, because that can often make bloating and pain a whole lot worse.
Right, so what happens if those lifestyle changes just aren't cutting it? That's when we move on to our stepwise pharmacological approach. The key here is always to target the patient's most troublesome symptom.
The whole game here is to tailor the treatment. If pain and spasms are the main problem, you go for an antispasmodic. If it's constipation, use a laxative like Macrogol. But please remember, avoid lactulose. It ferments in the gut and will just make the gas and bloating worse. And for diarrhea,
Low pyramid is your first choice, aiming for a soft form stool, not swinging them all the way to constipation. So, you've tried the first-line stuff, but your patient's still struggling. They're doing all the right things, but it's not enough. What's next in our toolkit?
This is where we bring in our second-line treatment, low-dose tricyclic antidepressants, or TCAs. Now, it is vital that you explain to the patient we are not using this because we think they're depressed. We're using it as a neuromodulator to help turn down the volume on those pain signals coming from the gut.
And when we say low dose, we mean really low. We're starting at just 5 to 10 milligrams of amitriptyline, taken once at night. You have to reassure them that this dose is way below what's used for depression. It's specifically for its pain-modulating effects.
The advice is simple. Start low, go slow. Counsel them to increase the dose slowly if they need to based on how they're feeling. The sweet spot for IBS is typically well below 30 milligrams a day. This approach has been proven to be effective in primary care.
Okay, last section. What's the long-term game plan? Because IBS is a chronic condition, right? So we need a clear strategy for follow-up, and we need to know when it's time to escalate care for those patients with really persistent symptoms.
This timeline gives us a really clear pathway. You'll want to see them back in about 4 weeks after starting a TCA, just to check for side effects and see how they're getting on. If it's working, great, you can do regular reviews every 6 to 12 months. But if after a good year of trying all the medical therapies, they're still struggling, that's your trigger to think about referring them for psychological interventions like CBT.
So to wrap it all up, if you remember nothing else from this, remember these 4 points. 1. Diagnose positively using the criteria. Don't make it a diagnosis of exclusion. 2. Investigate smartly, just the essentials. 3. Manage in clear steps, starting with lifestyle. And 4. When you use TCAs, remember the mantra, start low and go slow.
And that leaves us with a final thought to chew on. We're getting much better at managing the symptoms with this structured approach, which is great. But the next real challenge is figuring out how to tackle the root cause, that complex mix of biological, psychological, and social factors that drives this condition in the first place. How do we do that better in a 10-minute slot? That's the million-dollar question.